All right, let me share my screen. So I will say we have our first out-of-state dentist joining us today, Dr.
Hey,
Ryan Gilreath. Uh, Ryan and I did our maxi course together down in Augusta, Georgia. He has a similar size practice down in South Carolina. Super cool guy, does a lot of cool things. He said he wanted to check out, see what we're doing. So thank you, Ryan. You don't need to show your beautiful face. Just enjoy the ride. All right, so what we talked about last week was a treatment plan for this patient, Jackie. And we had gone through pretty much her full treatment plan, came up with a set of options, which we have here. We also had a problem list, so we identified she's missing teeth. She has a severe class 2, skeletal class 2 situation. She's also exhibiting some flaring of the teeth, and we had identified that when we see flaring, flaring is an indication of tongue thrust. So it's not too uncommon when you see class 2 situations that the patient actually has had airway problems their entire life, in great part because during their skeletal growth years, their airway was aberrant for some reason. They end up class 2 or retrognathic, and this is what happens. But if that tongue thrust continues through adulthood, we end up seeing spacing of the teeth, flaring of the teeth, and we've all seen the periodontal patient who's a smoker whose lower anteriors start to splay. Now that's a patient that might have a weak tongue thrust, and it wasn't until the teeth became weak enough that they couldn't withstand the forces of the tongue thrusting forward. So I'm just trying to paint the picture of what to look for when we look at splaying of teeth. I often use my 4 fingers to splay forward to show patients what I mean by that. We had talked about lack of mutually protected occlusion. What does mutually protected occlusion mean? When established well, again, a concept popularized by Dawson, the front teeth protect the back teeth and the back teeth protect the front teeth. So the back teeth take the force during MIP. The front teeth take the forces during excursions, both protrusive and lateral. And within that, we have canine guidance and group function. Obviously, occlusion is a loaded conversation, but it's important to understand here that this patient has lost mutually protected occlusion, or maybe never had it, which might be why we see more loss of posterior teeth than we do problems with the anterior teeth. So compromised airway, we took a look at her palate. We like to see something from 32 to 36 millimeters or more in between the molars, the first molars. Here, it may not be obvious if you haven't looked at palates with this kind of lens, but this is a restricted palate. So her palate is essentially not developed, in great part because she probably didn't have proper tongue posture as a young kid. When we don't have good palatal arch form, we have incompetent nasal passages, which can perpetuate the airway problem. So I'm taking a 10,000 foot view over what we talked about last week, in great part because treatment planning this case, I firmly believe these factors need to be taken into account. We had talked about severe recession, decay, pretty run-of-the-mill problems, post-treatment disease of number 30. In other words, it's a root canal treated tooth that needs some attention. Low sinus floor, so we looked at her CAT scan, so let's take a quick look at that. And we talked about pneumatization of the sinuses. Pneumatization being enlargement of the maxillary sinuses from some sort of chronic problem. Let me rephrase that. Some sort of chronic process. Some people have genetics that predispose them to having pneumatized sinuses. Some patients have chronic allergies, which means that they have inflammation inside the Schneiderian membrane, which can cause inflammation of the underlying bone. And if there's no tooth present, we get pneumatization. Well, this is a problem for the patient. When we treatment plan, it's easy for us to overlook the fact that we didn't look at the sinus. But how do you do a comprehensive treatment plan unless you send the patient to the oral surgeon if you haven't taken this into account? In addition, I find when we send to the oral surgeon, they may or may not, do a good job of explaining kind of the airway component to this problem. In other words, chronic sinusitis, what have you. They're really good at repairing it, but our goal as the quarterback of the treatment is to get the patient to understand that their tooth loss is probably related to their sinuses. Maybe not their maxillary sinus, but their sinus on the whole, maybe the nasal cavity, the turbinates, what have you. Basically, the upper airway is probably compromised. So I'm a huge fan of us figuring this out, not sending it to the oral surgeon for them to maybe involve this into the treatment plan. Odds are they're going to confuse the patient or not even bring it up at all. Not to say that we need to do the treatment, but we need to understand the treatment so that we can treatment plan the patient. Our goal with NECADE is to treatment plan a situation where we literally send the patient to the oral surgeon saying, please evaluate for sinus lift. Here's a copy of the treatment plan we are doing. In other words, we don't leave the door open for the specialist to put in their 2 cents. Even if they're right, I have found when there's multiple doctors, all with very good opinions, talking to the patient at separate points in time, the end result is the same, which is no treatment. We as the general dentists are the quarterbacks, and we should be good enough to sit down with the patients, have these conversations, let them know they need a sinus lift. I mean, there's an algorithm for this. Literally, how much bone do you need before you need a sinus lift? How much width? How much height? We'll go over that at some point in the future. Then we talked about areas of significant bone loss which may require grafting. I think we're talking more about the lower arch, maybe some ridge augmentation down in the lower left. So we hit all the high points. In her medical review, she had mentioned she has snoring. Really nothing else. She's probably 70 years old, plus or minus a few years, and that's it. And her goal is to have a healthy smile that lasts a lifetime. She didn't use those exact words, but going back to her chief complaint over here, I've had tooth issues over the past few years, and I don't know why I'm having these issues. It was the frequency of dental problems that caused her to finally say, you know what, Dr. Roy, let's take a closer look at things. So this is a classic case where I planted a seed probably in 2014 about comprehensive care. For one reason or another, the patient wasn't interested. I would say she was probably of the ilk where if it ain't hurting, don't fix it. If it ain't broke, don't fix it. But it was the frequency of her problems. She was tired of coming to the office on emergency. Even though she's a regular recall patient, she was tired of showing up on emergencies. All right, so then before I go there, I just want to make sure everybody's still here because all I hear is silence. Chad, thumbs up. All right, thank you. All right, so then we went over to strategies. We used to call these options. We now call them strategies. Is it important? Maybe. The reason we chose strategies is strategies are kind of collections of options. So I used to be very specific. Strategy or option 1 was a partial denture XYZ with an exact price. What I'm trying to do here, and I know we went over this last week, but I want to drive the point home. What we're trying to do here is paint a picture of the following. The patient has 4 or 5 or 6 ballpark strategies. They each come with their own pros and cons and their ballpark options. The goal here is not to get a patient to say, I want to do this plan. When we get specific, we open the door for problems. Patients don't like specificity at this point in time. They want to see a menu of options. Now, what I like here is it lays it out in chart form so the patient can see everything in one glance of the eye. So we had talked about the lack of value of presenting options to patients chairside when they're in an emotional state. We talked about the fact that when patients show up to the dental office, they're in an emotional state because dental work is emotional for many people. The costs associated with it is associated with an emotion. The list goes on and on. They're not likely to hear you. But if you lay it out in this kind of form and you send it to them in the mail, then they have the opportunity, when they're not in an emotional state or in a lowered emotional state, to read this and actually come to the following conclusion. The price that they get here is not the treatment they're going to get down here. And I've shared the story before. The moment I realized this was the right play, I had a patient literally tell me that. I am so glad I saw this, because I thought that I was getting this. And he, we're in the consult room together, and he opens up the folded paper, and you could tell he'd been carrying it in his pocket for the past 2 weeks, which was the whole point. He'd been thinking about this deeply. And he opens it up and he's like, I'm really glad that you did this, because I would have thought I was getting this. And he pointed to the pros or the advantages of option 4, the most comprehensive option, for the price of this option. And that nailed it home for me. From that point forward, I said, that's what, I couldn't articulate it that way, but that's what I was trying to drive home for the patients, was that you're not going to get predictability. You're not going to have comfort with some of the lower cost options. So how we construct these is going to vary from clinician to clinician. The options are going to vary greatly, which is fine. No two dentists are going to treatment plan the same ever. I have literally treatment planned a patient 3 times, and each time it came out different.
That's totally true. I can support that.
Yeah. Do you want to chime in? And, Zach, have we killed anybody by having different treatment plans?
Never. No. And, a lot of times patients love having multiple perspectives. I mean, having multiple doctors work on a treatment plan, and when you present them that plan, that one's always the best one.
There you go.
Yeah.
Yeah. I mean, we're getting them from. Here's a good analogy. You don't have a car. You go out and you're shopping for a car. There's a million different cars that are going to improve your quality of life dramatically. Now, what's the best car? Well, you could break out consumer reports, figure out the depreciation value on it, so on and so forth. Yeah, there's probably a right answer, but there's definitely no wrong answer when we do this. So be okay with the fact that you're going to have different treatment plans across other clinicians. But at the end of the day, it should make scientific sense, and it should be a situation where if you do it well, it should last 5 years. So at our office, we talk a lot about honoring our work. Well, you should be able to execute treatment plans that last for 5 years. Many clinicians say a year. Obviously, you should be good enough to say to the patient, this is only going to last a year, in which case you don't offer a 5-year plan. But if you give a patient a really good option, a comprehensive option, where you're controlling the occlusion, they're wearing a guard, they have a sleep device that they can breathe better at night so they're not under sympathetic activity, so on and so forth, dentistry lasts. If you look at some of Frank Spear's work he did in the late 70s and early 80s, still around today, and it's because he took into account many factors. So the sky's the limit when it comes to the options. Last week we went over and we came up with this set of options. So I'll go over this quickly. The first one was removable options. I don't think it's important to say partial versus complete denture. You're just trying to make the point that there's something chunky in their mouth. Its only advantage is it's low cost, and it's relatively quick because it's non-surgical. The cons, obviously, we could write a list a mile long. Just think of all of the things that we as clinicians hate about removable appliances. The second option was crown and bridge and removable. So the idea here was to crown some of these teeth and then make her a partial with surveyed crowns. So we know that when we improve the foundation at which a partial sits on, the success, the fit, and the feel for the patient for that partial goes up. So you could call this a removable option or an advanced removable option. Obviously, that comes with more expense. Back in the 80s and before, they called this periopros, or combination cases where removable was part of the solution and often viewed as a very nice way of solving patients' problems. The downside to that is we don't see those patients anymore. You tend to see patients that have crown and bridge options that might last 15, 20, 30 years. But when you put a partial in there, you're condemning the patient's dentition. That's a fact, been proven, which is why we tend not to do anything removable beyond option 1. As a group, we came up with option 2 together, which is fine. It's an option. And then we came up with the comprehensive option, and our goal, which comes out of the book Predictably Irrational by Dan Ariely. I know you guys hear me talk about this all the time, but it's such an important book to understand the psychology of how patients make decisions. It's not a dental book. When you read it, you're going to be afraid to go buy your next car because you're going to understand that they know those things, but the average consumer does not. What came out of that book for me anyways was the understanding that when you put a list of options, people will seldomly choose the final option. Now there's a handful of people, the 1%ers of the 1%ers, that thrive on the fact that if it's the most expensive, they just want it because they want to say that they chose the most expensive. I haven't run into too many of those in Buxton. So what we do is we set the stage, we frame it. The word frame is what comes out of the book. That sounds a little bit mischievous, but at the end of the day, if we understand humans are going to act in a certain way, then why don't we play to that so that we can help them make the best decision? And I've had associates say, Nick, you're fooling people, you're pulling the wool over their eyes. I'll let everybody resolve how they want to resolve this. All I know is I provide better dentistry for the amount of money that we offer our patients because I'm helping them make a good decision. At the end of the day, I'm the expert in the relationship. So if I can help them make a good decision, even if it involves framing it, knowing how psychology works, then I'll do that. There's no bait and switch here. It's purely just setting it in a way that you know they're likely to behave. At the end of the day, it's still their decision. So we had put the comprehensive option third. I always like putting solves all problems or solves all problems to the best of the ability given the situation. You know, you're trying to circle this without circling it by using the right words. So Luke had typed this in last week, highest likelihood of creating a healthy smile that will last a lifetime. So we talk a lot about circling back to their chief complaint or their goals. If we use the words that they use, we're connecting to their emotion center, their limbic system. And if we connect to their limbic system, they feel trust. And when they feel trust, they're more likely to make a good decision. So lots of little tricks that we do in here. Under cons, I always just put time and cost. You know, there's really no downside that I can think of that's worthy of putting here. Those are the two major ones, and those are the two that the patients are most likely going to balk at. So you might as well just put them front and center. Be honest with patients. Is time important to you? Is cost important to you, or both? Something to talk about. Well, we ran out of time. So here we are 20 minutes into it, kind of paraphrasing what we did last week. We ended up at full reconstruction via, and then we ran out of time. Oftentimes we'll use the all-on-4. This is not a situation where I would tell the patient all-on-4 is an option. Does anybody want to come up with a frame option? In other words, it's an option where the dental board would never balk at you for putting it there. There's definitely some dentists that might do it, but it's probably not what you think is right for the patient, or you're likely to think they won't choose it. All-on-4 again is, honestly, you could probably say all-on-4 here. How about this? All-on-4 is an option. Dr. Regan, would you like to say why? And I'm asking you because you have a very similar case that you and I talked about, and you made a very good case on why you thought it was good.
Why? Because of her occlusion.
Yes.
You get to reset the entire occlusion in one fell swoop.
Exactly. So we can reset the occlusion orthognathic surgery-wise. If I just made up a phrase, I apologize. I think you guys know what I'm saying. The other way to fix the occlusion is to remove all the teeth, reduce the bone in a way that you actually get some sort of occlusion. Good job, Zach. One might say she doesn't have that option. I mean, she's got a severe skeletal class 2 deficiency. So what other options could we do for her? Orthognathic surgery would be one. All-on-4s would be another. Our goal is to come up with an audacious plan that's likely to have a cost associated with it that's greater than option 3. That's always our option for the fourth option. Now, we didn't talk about ortho here.
Can you be a little bit more specific on what the comprehensive plan entailed? Did that include ortho and crowns of dessert?
Yeah, I don't recall what we. So this is what Luke was typing as we were talking. I would imagine we said ortho, and then implants, and then probably crowning all of the teeth to help create a better vertical dimension. And also, when you crown teeth, you can also, to some degree, help fix the anterior, posterior, or sagittal discrepancy. Have you ever seen a prosthodontist restore a case, and they have really, really thick lower incisors? And then you look at the upper incisors, and they have really, really thick linguals. Well, that's a technique to help increase the contact of upper and lower teeth when you have severe overjets. And I'm not saying we can do that here, but once we close all these spaces, there's a possibility we could get there. So yeah, Chad, I would say ortho, implants, any bone grafting that's needed, and then crowning many, if not all of the teeth, not because they need crowns structurally, but because we're trying to fix the occlusion. But I think if we close this arch form, we're probably not that far off from having at least a better situation. Any other ideas on how we might be able to solve this?
Did we talk about ortho already?
Yes. Could this be done with Invisalign?
Luke.
So Luke wanted to be here tonight. He's still getting caught up on treatment plans from his vacation. So he felt bad. He'll catch the recording. So for those of you who wonder why Zach said Luke is taking his 2-year orthodontic training down in Connecticut. So he's much more versed in the world of brackets and wires. I profess to have zero knowledge in that world. I've done lots of Invisalign, well over 100 cases. This is an Invisalign case all day long. In great part because that's not too exaggerated of a curve of SPE. We can definitely intrude those teeth as we splay them forward. All those rotations are pretty straightforward. Maybe we have a separate conversation about Invisalign. If anybody wants to learn more about Invisalign, I'd be happy to have a conversation. I have a group of orthodontists created this online mentorship. It's called Your Ortho Coach, YOUR. Ortho Coach is the website. And you pay them, I don't know, $200, and they help you with your ClinCheck for Invisalign. They'll help you with any of the clear aligner therapies. Basically, they help you with treatment planning for these kinds of cases from an orthodontic perspective. So I've done probably 20 to 30 of them over the years, and a lot of my learning came from asking different orthodontists who had at least 5 years of experience in clear aligner therapy their techniques, and they all do it super differently. Again, we talked about how if we put 10 dentists in a room and we ask them to treatment plan this case, we're going to have a whole wide array of options here. The clinical approach for treating cases from an orthodontic perspective varies greatly. Moral of the story, did you improve the patient's life dramatically? And is it commensurate with the amount that you charged? And are they happy? So happy to share those with you. I have all of the videos that those people have done. So they did a video recording kind of like this, talking about what attachments they would use, how many trays they would use, whether they would use elastic, so on and so forth. So this is a very easy case with Invisalign. The question is, when we straighten both arches, will we still have a sagittal discrepancy? So I keep using the word sagittal. I can appreciate that that word's probably not something we use comfortably. Sagittal is the anterior posterior dimension. And when we talk about class 1, class 2, class 3, we're talking about the sagittal dimension. All right, so I have one alternative option, and I have done it twice, and it has worked out beautifully, and I'd like to publish it someday. I'm finishing the case right now. It's similar to this. Basically, the patient had a skeletal class 2 situation, not this severe though. She had an implant placed years ago in number 9. I was somewhat restricted in how much I could retract the upper segment. Retract meaning pull it back. So I had only one option, and it was to create spaces in between the lower teeth, thereby increasing the arch form. And then I did resin composite veneers in between the teeth. I created about 0.5 millimeters, 0.5 between each space. So a millimeter between each tooth. And then I restored those, thereby increasing the contact of her anterior teeth. So I corrected, through a restorative approach, a sagittal discrepancy. So that's one final way we could do this. One risk of doing that: when we do Invisalign and we straighten these teeth, we run the risk of periodontal defects down here. I then furthered the proclination of those teeth to create spaces so that I increased the contact of the upper and lower teeth. What's the risk of that? Destabilizing the periodontia down in this area. So what I did before I offered that option to the patient, I made sure that she had at least 2 millimeters of keratinized tissue on the facials of all of her lower anterior teeth, which she did. Anybody ever seen this done or have any thoughts about that technique? Now, those two cases came out great, but I'll share a failure that I had that I'm currently fixing. Patient, very similar degree of crowding, wanted to straighten her teeth. We did Invisalign, and all of a sudden she had one of those unzippings of the facial plate, or a fenestration. I did not properly assess the amount of buccal bone and buccal hard tissue, not hard tissue, but keratinized tissue on the facial of that tooth. Well, she was pretty upset. I did not properly set the potential downsides to the case with the patient. So, super sweet lady. I sent her to the periodontist to have soft tissue grafting. They ended up grafting all of the teeth in the lower segment except that one tooth. And they told her that it wasn't possible. It's a Miller Class 1 situation. If you guys remember Miller classifications, Miller Class 1 is basically when you have a full papilla here. I have no idea. It was a newer periodontist, and they basically threw me under the bus. Moral of the story, the patient's getting all of her Invisalign and the perio treatment done for free. Why is this important? One, I don't want to profess that things I do work every time. It's definitely not the case. I promise you I fail as much as the next guy. That's a situation I could have predicted, and I'm much better at now. When we talk about moving teeth, even if the orthodontist is going to do it, we should have the conversation with the patient. Are they at risk for recession, especially in the lower anterior? How do you assess that? Do you have 2 millimeters or more of keratinized tissue from the gingival margin apically? And when you probe, is there a healthy pocket? If you have those two criteria met, you have a low risk of having issues. Fast forward to our CAT scan, we now have the ability to actually look whether there's bundle bone there or not, or a buccal plate. It's very possible she never had a buccal plate to begin with, and I moved the tooth, and all I did is unzip the tissue. So there's things that we can see on the CAT scan that are very, very not obvious, that we can build into our treatment plans. All right, so the fourth option, let's just say we did all in fours. We put all in fours there. We can justify that that's an option based upon the fact that she has a severe skeletal discrepancy. Let me show you what my treatment plan came out to be. Again, this isn't the right answer. This is just what I came up with maybe a year ago. All right, so I had upper and lower partials. I put 5 to 9K. We came up to 6 to 8. Then I had implants only. So I did not have another removable option. Instead, I said, what if we just put implants in? The upside to that is we increase her function, we decrease the stress on adjacent teeth, and it's a relatively low cost. Relatively meaning this price here is significantly less than this. The downsides are cost and time. I probably could have put here, many of the issues are not addressed. So I try to use that language a lot. How many of the issues on page 1 are we addressing? This has been such a beautiful way for patients to understand whether or not they're choosing a comprehensive option or not. Because if they're not choosing a comprehensive option, in their mind, they're spending a lot of money and it should work. But if you make the point that some of the problems are not going to be addressed, that implies that the future is uncertain. So you do a full mouth rehab-ish, of this kind. I say a full mouth rehab. You treat some of the issues, say with implants, and then you go to put that implant crown on and you throw off their bite just right, and all of a sudden they come back with a broken premolar on the opposite side of the mouth. Well, they may or may not blame you for that. That happens often, by the way. Many of us have experienced that, where we do something on one side of the mouth, a week later they have another problem somewhere else. That's because we destabilized their occlusion and threw off the system because the system wasn't stable. Well, we didn't offer system stabilization here. In the comprehensive option, we will do that. We're going to get a wax up and make sure the teeth are all aligned and do a equilibration with a T-scan. Advanced options, and that's why you see something as expensive as this, because there's a lot that's involved. Here we put all issues are addressed, and then I put another pro, best option without large surgery, because here I put option 3 plus orthognathic surgery. So these are two different options. If I did another one in a week, I bet it would be different than this, but that was the goal for the patient, was to come up with a set of strategies. Here, back then I called them options, now we call them strategies, to set the patient's awareness about how significant their problems are and what it's going to take to fix them. And if we choose an option that doesn't fix them all, they need to know that. Thoughts? Everybody sleeping?
Can I ask you a question?
Yes, Elena, thank you.
I forget. I'd have to look at the cast. I think it was between number 3 and 4. There was kind of an awkward, or what do we call that number 2 actually, right? We decided, yeah.
Yep.
So if you do ortho, are you trying to reopen that space to place an implant? I forget. I think you briefly talked about it last time, but I don't remember.
Yeah.
Or are you trying to close the space with ortho and make it push it into the first molar position?
Yeah, good question. The first thing I would ask is, how is the bone around the tooth? So when a tooth shows you signs of something like this, we have to assume that the bone underneath it is probably compromised. And if we're going to move a 3-rooted molar through bone, we better know what the bone is like so that we can make a better decision on which direction to move it. So if we come over to the CAT scan, so here's the area here. All right, so I'm bringing the cross-sectional view into focus. What I'm trying to do is get a sense of the bone around the tooth by looking right here. Because I want to know, is that bone above the furcation or below the furcation? If it's above the furcation, which I doubt it is, that tooth has a better prognosis than below. And that's going to help guide me in the direction of how I'm going to treatment plan that. So I can see right here, the bone comes up. That's the furcation right there. Let's zoom in on that. All right, so that's the level of the furcation. That's the level of the bone. Now I have tissue there, and I likely have tissue here, but you can imagine if I start trying to move that tooth, that's sitting on very unstable bone, and I'm likely to create a further periodontal problem as a result of that. So that's thought number one. How is the bone around the tooth for a situation where you have a severely tilted tooth? The other part is when we close spaces orthodontically, it's always harder to move the tooth in a direction away from the apex of the tooth. So here's the apex of the tooth. This would be away. Let me rephrase that. The crown in relation to the apex. If we move the crown away from the apex, we're likely to create even more of a problem because it's very difficult to do what's called root torque angulation. So in other words, taking this root and moving it so that it's parallel to this root is virtually impossible for this kind of situation. A little bit easier maybe with the anterior teeth. Bracket and wire orthodontics do a better job of root control. But in this situation here, I would feel very comfortable pushing the tooth backwards and opening the space, letting the patient know that this tooth is likely to get worse. I would cut the tooth down, almost like the first step in a crown prep, which is fine because we're going to be crown prepping it anyways at some point in the future. Reduce that so that I have no interference interocclusally as I upright that tooth. So that's a much more predictable motion when I'm taking the crown of the tooth and I'm pushing it towards where the apex is. Biomechanically, that's favorable. How does that sound, Elena?
That's interesting. I never thought about taking it down. So you would only take it out of occlusion enough and then get it in the right spot and then you'd prep it. Is that what you're saying?
I would prep it first. And the reason is when you orthodontically move teeth, the bone at the crest is always going to behave better than the bone that's at the tip of the root. Mm-hmm. That's one of the hallmarks of orthodontics is you're going to get what's called dumping. So you go to push this tooth backwards and you would think if you create good force mechanics that for every millimeter you push back here, you're going to get the same millimeter here. In reality, you're going to get half a millimeter here and a millimeter here. And when you do that, the tooth actually uprights. So right now it's in occlusion. If I put a distalizing force to it, I'm actually going to create a tooth that's taller, and we would create a interocclusal interference. Mm-hmm. So I would reduce the tooth, obviously maybe not getting into the dentin, but I feel like there's enough restorative material here that we could reduce the tooth, give it some sort of shape before we do the Invisalign, so that as we do the Invisalign, this tooth does not become an interference. And I'm okay doing that because I know that 1 to 2 millimeters of occlusal reduction is also the first step in the crown prep.
Makes sense.
Although the crown prep will probably be a year down the road, I'm at least comfortable knowing I'm reducing tooth structure that will be reduced down the road anyways.
Thank you.
Yeah, good question. Any other thoughts? Where we have a space here, Invisalign trays would get in here and be able to grab quite a bit of that mesial surface of the tooth. That's a pretty predictable movement for two reasons. One, we have that space, so we have a pushing force for the plastic to push on. And then two, the bone isn't really that significant around it. So that would be a pretty easy rotation. When we're done, the keratinized tissue that's around it may recess or become receded. Um, I would not do it because of it. This right here is a periodontal nightmare, long term. This tooth, as it sits right now, is far worse off than if you uprighted it and then did a gingivectomy to get rid of all of that attached tissue that's in the way, or do a apically repositioned flap where we actually take the tissue and push it upwards, and then you have this huge furcation. Well, a huge furcation that the patient can keep clean, in my eyes, is better than this situation. This is likely to cause a problem to this tooth, which currently doesn't have a problem. Not to mention, this is tilted teeth in the posterior are occlusal destabilizers. We talked about this Maryland bridge here. Really, we would like to place an implant. All right, so that was page 2 of our treatment plan workup. Page 3 is the following. How do we phase this? So in my initial workup, I always do a phase plan for a patient. Why would I do a phase plan when I haven't yet had the patient tell me which of the 4 strategies they're willing to choose? Well, I say to myself, what is the best option? Typically, it's the comprehensive, least surgical option. Sometimes the all-in-4 is the better option. In this case, it's not. I basically lay it out so the patient can see that we can phase this over time. By giving them the understanding that phasing can be done, it gives them a little bit of freedom to understand that this is possible. Even if the phase plan that I put on page 3 as this initial workup is done, even if that plan is not the one that they choose, we still paint the picture that this can be done over 3 to 5 to 7 years. I definitely have several cases that are pushing 6 years. I don't know if I've got any beyond that. But for one reason or another, the patient needed to stage the treatment, which is why we do a lot of lab fabricated PMMA bridges. You know, a good example would be here. We do some ortho, we do some grafting, and then the patient lives in a PMMA bridge across these 5 teeth. The PMMA bridge is either cemented with Duralon or even Fuji Plus sometimes, just to buy the patient some time while the bone graft heals. Then 2 years later, you come in. If you did Duralon, you pop off the bridge, place the implants, put the bridge back in. They heal for 3 to 5 months. So staging cases is one of the most important tools that we'll have in our toolbox to give patients the confidence that we can help them even if their budget is restricted. So let's take a look at what my plan was when I did the workup. All right, so I didn't spend a whole lot of time in this. I'm just trying to give the patient a very broad picture on what could be done. So first thing I said is improve bite. Let me bring up her iTero scan. Let's leave it right there. All right. First step in phase 1, improve the bite. We talked a lot about sleep. Well, I want to get some more information on how her sleep quality is. She put on her medical intake form that she is a snorer. So I definitely want to have more information there because it's going to dictate my treatment plan. For example, if we determine she has sleep apnea and for whatever reason the patient ends up getting to the oral surgeon to have an orthognathic surgery consult, I don't know if the oral surgeon is going to be an airway-driven oral surgeon, but I'm going to tell the oral surgeon, do not retract the upper maxilla, advance the mandible only. Most oral surgeons are probably going to laugh, saying, why is the general dentist telling me what to do? You send them a paper that says mandibular advancement in sleep-compromised patients for orthognathic surgery is the right play. This comes out of their literature. It helps support your decision-making so that the patient doesn't come back with a retruded maxilla, advanced mandible, and all of a sudden a worse airway problem because their tongue doesn't have enough space because the maxilla was retracted. And then possible bone grafting. So that's one option or one kind of strategy that we can choose when we phase the treatment. Anybody have any questions about that? Phase 1. All right. This little arrow here with 0 to 2 years, I'm trying to tell the patient that they don't have to rush between phase 1 and phase 2. Sometimes we need to, sometimes the patient wants to if financial restraints are not part of the equation. But I have found by putting this, patients feel somewhat at ease to know that, well, I have a flex spending account. I can only put so much per year in. If I had 2 years worth, I might be more likely to do the second phase. These kinds of things come up all the time. So here in phase 2, we place the implants in the selected sites. So here we've uprighted number 2, we've placed an implant in number 3, we bone grafted here. That needed a sinus lift, so that's something we would have done in phase 1. We maybe did some bone grafting here, and then probably some bone grafting in the lower left, and implants, same with this number 23. And then we talk about crowning the teeth as needed to reduce the risk of future issues. So that's where we talked about crowning the teeth to improve her occlusion. That might include both arches. It might include one arch. It might include just posterior teeth on both arches. It might include anterior teeth in both arches. So there's lots of different ways to solve the problems. We don't know what the answer to that is until we know how we're going to move the teeth, or if we're going to move the teeth. So patients often want to know, how much is it going to cost to crown all the teeth? It's like, well, you're going to do Invisalign. Well, I don't know. So giving the patient these frameworks allows them at least to have a fighting chance on understanding all of the complexities that go into a complex treatment plan. And then phase 3, rebuild the new bite with crowns on newly placed implants. I guess 2 and 3 kind of dovetail together. We're improving the occlusion. And then lastly, we always put maintenance of investment. We don't want patients to think that when they're done this, they get to never visit a dentist again. We also want them to know that we often want a bite guard, especially if we don't treat their airway. Definitely want to have a protection to their investment, an insurance policy of sorts. Much of the time, especially cases like this, we're going to make them a sleep appliance, which is going to dovetail as a bite guard at the same time, doing 2 very important things all at once. And then I'd just like to put something here that kind of drives the point home. The end result of this is much less risk for future issues. This comment came from here. Right here. Prevent future issues. Those were words that she had used. Here I put end result is much less risk for future issues. So I'm implying if we do this, she's going to have the best chance for long-term predictability, which also sets the stage for the following. If she chooses option 1 and it doesn't work out well, for whatever reason the partials just don't fit well in her mouth, we've all had those cases that go sideways. Subconsciously or consciously, they know they chose an option that was not ideal. They're much less likely to give you a hard time if you went through this thorough process than if you were to just say, all right, here are your options, partials, bridges, or implants. Well, how much are they, doc? And then you give them ballpark options while they're sitting in the chair. Then they choose the partials. And you're like, all right, we'll see you on, in 2 weeks for final impressions for your partials. They come in, you guys know the rest of the story because it happens to all of us. That's dangerous. I don't like practicing that way. I want to practice predictably, and if the patient chooses an unpredictable option, I want them to own it. I do not want to own it. This process has removed a lot of that ambiguity in the process over the years. All right, so we have 8 minutes left. Anybody have any thoughts about this treatment plan? One might ask, what did the patient do? She's still thinking. I'm not sure why I chose this treatment plan. I have lots that I've completed that went through this process. I think it'd be cool to go through one of those maybe next time. I'll do one that the patient did go through with treatment and see where we ended up. Sometimes it worked. Sometimes there was future headaches that I did not see coming. The whole point of this is for us to share experiences so that we can share in the misery of others in hopes to avoid that same misery down the road. All right. So one thing I wanted to go over, is Greenbaum here? I don't think he showed up on the call. We did some buffering today. So buffering with sodium bicarbonate. He had a patient, we did sedation today. I did the sedation, he did the full mouth rehab. The patient just had a hard time getting numb. Last 2 times he saw her, he was at the 10 carpule max, just doing 1 arch of fixed work. And she didn't have any inflammation, or didn't have much inflammation. Well, there's something about her that makes her run through the anesthetics more, or it prevents the anesthetic from working as well as it should. So we did the sodium bicarbonate technique today. I'll go over what we did shortly. I just want to share this diagram. This is the best diagram I've ever found explaining what happens when we use local anesthetics. Yes, in dental school we probably had a version of this, but to me this is a much more clinically relevant picture than anything I've ever seen. So let me go over this quickly. So the mechanism of action of all local anesthetics. You have your chloride ion that separates from the anesthetic itself. Essentially, this is the ionized version of the compound. So lidocaine is ionized, and then you have your free chloride ion, and then you have your non-ionized versions here. pKa, which comes from your Henderson-Hasselbalch equation, basically says what percentage of these live, let me take that back. At a pH of 7.9, you have 50% here and 50% here. It means that they live in equilibrium. That's how Henderson-Hasselbalch says this. Well, we know that our physiologic pH is not 7.9. It's closer to 7.4, which means that we probably have more of the ionized version. So out comes the syringe. Here it says pH of 6. The pH is inside the carpule. You can't have the pH be any higher than that, otherwise the compounds would be unstable. If they're unstable, their shelf lives are shorter, so they have to keep it at a pH of 6, but you're injecting it into a situation where the pKa is 7.9 and the extracellular fluid is 7.4. What that means is the body doesn't get enough of the ionized version to actually have an effect. We want more of the non-ionized because that's the lipophobic version that will cross the phospholipid bilayer so that it comes into the nerve sheath and then disassociates and creates the ionized version, which then has an effect on the sodium-potassium pump. What does this all mean? Well, if we change the pH right here through the use of a buffering agent, we increase the amount of the lipophobic version of the anesthetic so that more crosses, and when more crosses and gets inside, you get more chance for anesthesia. So he has a patient that, for whatever reason, it doesn't work well. Well, she's just one of those people. You see her, she's got kind of that red tinted hair, light skin. I don't know if it's lower pH, but I literally think they have a lower pH. They're more immune to having inflammatory issues post-operatively. Those are patients I'm more likely to give steroids for, like a Medrol dose pack, depending on the surgery that's being done. Moral of the story, when we use buffers, we increase this. When we increase that, more crosses over, we have a higher percentage of free ions that can then cause anesthesia. Well, Dr. Greenbaum's worked on this patient several times, and he used, in his words, very few carpules of anesthetic. So what I did, this is a company that makes a system that will do it for you. It's very expensive, especially for a big practice like ours, and I'm sure the doctors will start using it. I'm trying to find a solution. So I came up with this buffering tub, which I haven't put together yet, but I have all of the components. I basically took a 100-unit diabetic syringe, and I drew up, this is the little ratio that I put together. 18 units. So about 20 units in the syringe. And I injected it into the carpule. Before I did that, I withdrew 20 units of the local anesthetic and just discarded it in the sink so that I created enough space. You'll actually see the plunger moving when you do this. Again, we're going to go over this in the future. I just wanted to kind of lay the groundwork for the power of this technique. Worked out very well today. I've done it a few times in the past. It's been cumbersome because I didn't have the right equipment. We now have the right equipment. Our nice ionization dissociation curve. That's about it. Anybody have any thoughts or questions on this? This is great for the patient who comes in who's in a lot of pain. When they're in a lot of pain, it's because they have a lot of inflammation. When they have a lot of inflammation, they're likely to be acidic. If they're acidic, their pH is lower. Therefore, they're going to have less chance for this to cross through. This is why it's harder to get active infections numb. It has to do with the pH, the pKa, and the disassociation of the two. All right. That's enough babbling for one night. Good night, everybody. August 1st, we only have 1 month of pure summer left. Let's enjoy it. Thank you all for being here on a beautiful night. The good news is we still have an hour of daylight. Go enjoy it.
See you.
Later.